Good morning, everybody. After this malignant presentation, I would like to show our benign non-malignant cases. First of all, this table shows that our department is a regional center for these problems. We operate over 500 and right now over 600 patients with over 600 patients with these problems. First of all, what is upper airway stenosis? What is upper airway? Upper airway means, as this average chart shows, the nasal cavity, oral cavity, pharynx, larynx, trachea. And as this picture shows, the narrowest part is this laryngotracheal space, so that could be the most severe cases. As this endoscopic picture shows, there are several different types of stenosis, several different levels of this airway. This picture shows that vocal cords are not moving, they are just closed, they are paralytic, that's why there's less of air. In this picture shows that in the anterior part of the vocal cords are scared and unified. This picture shows that in the posterior part there is scar, and that's why they can't open during breathing. These are the glottic stenosis, which appear at the level of the vocal cords. This is combined stenosis anterior and posterior of the glottis. In this picture, you can see there's something scar under the. Unfortunately, picture not so good. The scar under the level of this glottis or in the trachea. What are the main symptoms? In severe cases, the patient has severe inspiratory stridor, which means that the inspiration is problematic, so they hear this kind of noise, and very often these patients require immediate solution. The traditional one is just to make a small hole under this region, the tracheostomy. But this thing to live long with this tube has very severe complications. It causes psychological, social, and also problems. It also has severe morbidation. So that's why in the past 20-40 years, several different techniques were introduced for different kinds of stenosis. Basically, only open surgery is thought to be effective in severe cases, because if you manipulate anyhow in this region, after we can expect some red stenosis, which may aggravate the status. So that's why these are simple cases. In case of tracheal stenosis, you may cut the stenotic part and cricotracheal segment resection can be performed, or the narrow airway can be augmented by rib graft, just this picture. So, but these are huge, long-lasting, complicated surgeries on one hand, and all these pictures were taken in patients they were younger than 1 year, and these things are long-lasting, expensive operations, and they had to be done in contribution of chest surgeon, cardiac surgeon, pediatrician, ENT surgeon, and the anesthesiologist. And that's why on the other side there are these minimal invasive operations, as my colleague said before. These also can be used for benign lesions as well. For visualization, this is the laryngoscope and the laser setup under the control of the microscope or endoscopes. The patients cannot be seen because they are much smaller than the instrumentarium. They all were newborns. Yes. First, as I mentioned, there can be some scar in the anterior commissure. You may see this only this is the black means the place for the and with the laser we can cut this gray scar here, but after it's known that after single cutting, some wrist stenosis may appear. So that's why something should be inserted there for until the heating of this surface to keep it apart. It was a silastic tube like this, and after 6 weeks it could be removed, and later on the patient is doing well, don't have any more this tracheostomy. In the late result it was shown some wrist scarring, but the black is much like, unfortunately the whole picture is black, but the trachea is much wider than it was before. This was anterior stenosis. Almost the same situation can appear in the posterior part in case of long-term intubation. If you have accident or any problems, that's why you need to be intubated ventilated for longer than 3-4 days. You may develop these posterior glottic stenosis in which the vocal folds are blocked in the posterior part, so they can't open. And in these cases, by the cutting and the articulation opening, we may open this glottis, and in this technique we used bilateral lateralization of these vocal cords to keep this wound apart until heating. So therefore we don't need to put any silastic flap or something for healing. And here is this 3-year-old boy or girl had a combined stenosis. This endoscopy preoperative endoscopy shows that this massive scar here in the anterior and the posterior part of the larynx. And that's why first we see what it is under control of the microscope. The anterior part is cut. Then the posterior part is cut. And finally, the larynx is opened and fixed by the suture as I mentioned before, and the much more space could be gained compared to the original status. And after 2-3 months, an almost normal condition could be seen in this case. And also, this is the most important thing, that her voice is almost acceptable. So you can't believe that after a huge cutting, it's working so well. There could be some congenital diseases. If you see this picture, the whole of the larynx is there. The epiglottis is very floppy and it blocks the hole. This is a feeding tube, it's going to the stomach. Here is the opening of the larynx. This is closed. Or this picture shows that this area epiglottis, this fold is very slow, that's very small, and that's why the opening is much smaller than it used to be. It had to be. And in these cases, we can cut these tiny folds to make it open. But first, earlier we have heard something about the continuous wave and the pulse mode of the laser. So here we can see the black caramelization zone, tissue defect, but in the other picture that's much smaller. It's only white and not black thing. Ultra-Dream Plus is the name for this technique. So these are the new modes which combine with the microscope techniques, that's what is mentioned. These techniques can reduce the thermal tissue image and minimize this necrotic zone. So here the continuous wave power, and this is the ultra-Dream Plus mode with the setting of the relaxation time decreases the thermal spread and spread by allowing surrounding heated tissues to cool down, so we can reach much higher peak power, and we can accept here is the difference. The modern cutting and the previous one. It's much better, I think. So finally, as conclusion, we may say that traditionally this transfer surgery played only a limited secondary role in treatment of upper airway stenosis, only in mild, simple cases. But with the new techniques, new minimal invasive methods, that's the keyword, minimal invasive methods, and we preserve the quality of life. That's the big thing, the quality of life, the minimal invasive method, with shorter clinical stay and costs. And the new modern ultra deep pulse laser technique may extend also the indications. They can decrease the post-op chance of risk of stenosis. And the combination of different, as I mentioned, different techniques may also improve the result. Thank you very much for your attention.
Thank you very much. Balázs, you can fight again for the two keywords for the ultrapulsation mode when it's helping to me for causing minimal damage surrounding the surgical area. It's also helpful for the patients to early healing, for the healing effect is better and shorter. Okay, it's also for the cost benefit, not want to stay for more in the hospitalization area. Right? First of all, I'm talking about for some benefits. For what's the benefit for the laser beam? Don't have contact with the tissue. All right. Sometimes is not always useful. You know, for our new colleagues, Mr. Gabovas is explaining for the new style for the surgical technique, because we're using for the diode laser, but it's actually for the contact lasers. Also, it's working for the near infrared, but more closer for the normal visible light, and that needed for the contact between the tissue and